I don't believe we have a National Health Service, and that's why I think this reorganisation offers us the chance to create one. What do I mean by that? Well, I sometimes use the lowercase n, NHS. We certainly have a national access service. It's a bit like an insurance company where people can get access to healthcare to the same, with the same rights anywhere in the country. But we can't answer the question such as, is epilepsy care better in Liverpool or Manchester? How many asthma services are there in Cheshire and Merseyside? Who's responsible for breathlessness and the management of breathlessness in the Wirral? Surely if we had a National Health Service, we would know how many liver services there were for the whole of England. We'd know who's responsible for the liver service for Warrington. Might be someone in Liverpool, might be someone in Warrington, but we would know. We'd have population-based, accountable, integrated systems. What is a system? A system is a set of activities with a common set of objectives and an annual report. It's delivered by a network, a set of organisations and individuals, not by a single institution. And patients find their way through networks, through pathways. So we need population-based systems. How will we create these? Well, the first will be cultural change. We need to move away from primary and secondary and tertiary, the great blocks of ice bumping into one another occasionally and worrying about the primary-secondary interface, to start thinking about symptoms such as headache, or populations such as frail elderly people, or conditions such as rheumatoid arthritis. That's a cultural change. We need to move away from the culture in which institutions are the most important organisation of health service to a matrix in which both institutions and systems work together. The model is the ant, the leaf-cutter ant. It's a complex, adaptive system. We need to work together, to collaborate. We might all have to make little sacrifices to make things work better. What are the implications for the clinical professions? For me, the most important implication is that clinicians need to think of the population they serve as well as the individual patient. I think when a clinician is with the patient, eyeball to eyeball, they absolutely focus on that patient. But all, or at least some, professionals have to think about the population they serve. See, broken legs aren't a problem. If I get run down in the street outside, I don't need good general practice or the right health beliefs. I'll be scooped up and taken to the appropriate service. Cancer gets to the service, maybe too late in some places. But everything we know about joint pain or rheumatoid arthritis or epilepsy or seizures or breathlessness or asthma, that people, the distribution of care between self-care, informal care, generalist care and specialist care is inappropriate. So we need people to think of populations. Now GPs, of course, think about populations. That's part of the tradition and culture. But we're very keen for specialists also to think about populations. And I'd emphasise it's not just single disease systems, it's frail elderly, for example, or people with multiple morbidities. So what we're seeing is a future in which we will be thinking in systems. It'll be clear who's responsible for delivering a system of care in a particular location. That may or may not bear any relationship to the geographical boundaries of CCGs or local authorities. Will be clear what the objectives of the system actually are, and we'll know that when we see the annual report and we can compare annual reports. And this will require clinicians to think in terms of populations as well as individual patients. And it also require the new culture to think like ants, complex, adaptive systems. We're going beyond bureaucracy, beyond the market, to get people working together, patients, commissioners and clinicians. That's how we see the future.